Major depressive disorder, otherwise known as MDD, is a common condition marked by low mood, loss of interest, and difficulty functioning in daily life. It affects over 280 million people worldwide and is a leading cause of disability. Since many patients don't respond to medication or therapy, alternative treatments are needed. Understanding the neurobiology of depression is important as it helps us to link psychological symptoms with underlying mechanisms within the brain. Research by George et al. And Shalene et al. Showed that one of the key factors in depression is an underactive prefrontal cortex. Since the prefrontal cortex is crucial for regulating other brain regions, reduced activity here can weaken top-down control. As a result, areas such as the limbic system become less regulated, leading to heightened negative emotional processing. Similarly, reduced connectivity between the PFC and the default mode network contributes to rumination and negative self-focus. Another key factor in depression is neurotransmitter dysfunction, which can involve reduced presynaptic release, abnormal signal transduction, or impaired intracellular signaling. For example, serotonin plays a major role in mood, anxiety, sleep, and appetite. When serotonin levels are low or when signaling is impaired, symptoms like low mood, poor sleep, and appetite changes often emerge. Norepinephrine is critical for alertness, arousal, and the body's stress response. Dysfunction here can leave individuals feeling fatigued, unmotivated, or overly sensitive to stress. And finally, dopamine is essential to reward, motivation, and pleasure. When dopamine signaling is disrupted, people often experience anhedonia, which is the core symptom of depression. So what is TMS? Transcranial magnetic stimulation, or TMS, is a non-invasive brain stimulation technique. It uses magnetic fields to generate small electrical currents in the brain. This modulates how excitable neurons are, with high-frequency stimulation generally increasing activity and low-frequency decreasing it. As seen in Figure 1, when high-frequency TMS is applied to the brain, action potentials are generated in neurons beneath the skull. When an action potential occurs, the electrically charged neuron becomes more positively charged in a process called depolarization. This triggers the release of neurotransmitters into the synapse. These neurotransmitters then bind to receptors on the postsynaptic neuron, propagating further signaling. Broadly speaking, TMS alters how neural circuits communicate by either strengthening or weakening connections across networks, which then ultimately influence brain function and behavior. There are several TMS protocols currently used to treat depression. Repetitive TMS, or rTMS, is the standard approach, daily sessions over 4 to 6 weeks. Theta burst stimulation, or TBS, is a newer and much faster option with sessions lasting only a few minutes. Deep TMS uses a special coil to stimulate deeper regions and broader circuits. An accelerated TMS delivers multiple sessions per day, aiming to achieve faster results within a shorter treatment period. Moving on, we now look at research into the physiological effects of TMS. As mentioned earlier, weaker top-down control from the prefrontal cortex over neural circuits contributes to various symptoms of depression. Research by Riedel and colleagues shows that TMS can bidirectionally modulate prefrontal limbic activity, increasing or decreasing connectivity depending on frequency. This evidence is promising because it suggests TMS could be tailored to restore regulatory control and reduce overactive emotional responses in depression. However, since this study was in healthy participants, further clinical trials are needed to confirm whether these effects translate into therapeutic benefit for depression. Furthermore, research from Liston and colleagues found that TMS reduced hyperconnectivity in the default mode network, especially in the subgenual cingulate, a region strongly linked to depression. Importantly, it also strengthened the anticorrelation between the DLPFC and DMN, meaning the prefrontal cortex regained its ability to suppress negative, internally focused thoughts. Next, we look at how TMS affects neurotransmission. Research by Pogorel and colleagues demonstrated that TMS induces the release of dopamine in the ventral striatum, a key finding given the role of anhedonia in depression. A strength of this study is its use of SPECT imaging, which provides objective neurochemical evidence rather than relying solely on behavioral outcomes. However, the sample size of just 5 participants makes the results preliminary and highlights the need for replication in a larger trial. In addition to this, an interesting finding by Lebhuber and colleagues found that TMS reduced levels of phenylalanine and tyrosine, which are precursors for dopamine and norepinephrine. This suggests that TMS promotes utilization of these precursors to enhance neurotransmitter synthesis. Taken together, these findings strengthen the case that TMS exerts its antidepressant effects in part by improving dopaminergic transmission. However, studies with serotonin are lacking. In this diagram, we can see how the PFC is linked with depression through various mechanisms within the brain. In depression, reduced PFC activity weakens connectivity with the striatum, lowering dopamine signaling. This contributes to anhedonia and reduced motivation. With TMS stimulation, striatal connectivity is restored, boosting dopamine release and helping to improve motivation and reduce anhedonia. Next, in the amygdala, underactive prefrontal control allows the amygdala to become overactive, increasing cortisol output and heightened negative emotional processing. With TMS, inhibitory control over the amygdala is improved, reducing excessive cortisol release and ultimately reducing stress-driven reactivity. Finally, in depression, the default mode network becomes hyperconnected and is coupled with the amygdala, fueling rumination and negative self-focus. TMS reduces this hyperconnectivity, improving cognitive flexibility and reducing rumination. Altogether, these changes illustrate how TMS rebalances dysfunctional circuits in depression by restoring striatal connectivity, re-establishing control over the amygdala, and reducing hyperconnectivity in the default mode network. Large randomized controlled trials provide strong evidence for the clinical efficacy of TMS in depression. For example, O'Riordan and colleagues conducted a multi-site randomized controlled trial with 301 participants, showing that RTMS was both effective and safe, particularly in treatment-resistant patients. Importantly, remission rates were about twice as high compared to sham stimulation after 4 to 6 weeks. Similarly, Levkovets and colleagues studied 212 patients using deep TMS. Results demonstrated moderate to large clinical effects within 4 to 6 weeks, and improvements persisted for up to 12 weeks during a maintenance phase. These trials are methodologically strong given their randomized, controlled, and relatively large sample sizes, which increase the reliability of findings compared to smaller studies. They also demonstrate replication across techniques with both RTMS and deep TMS showing clinically meaningful results. In further research, looking at TBS, a meta-analysis of 9 randomized controlled trials found it matched the efficacy and safety of standard TMS, with the added benefit of being much faster, making it practical for clinical use. For accelerated TMS, evidence shows it reduces depressive symptoms, but when directly compared to standard TMS, efficacy is similar. This suggests ATMS mainly speeds up delivery rather than outperforming conventional protocols. While some findings, especially for ATMS, come from smaller studies, overall the evidence indicates that TBS and ATMS can improve treatment efficiency without sacrificing safety or effectiveness. Looking ahead, an important future direction for TMS is protocol innovation. Traditional TMS requires daily clinic visits across 4 to 6 weeks, costing thousands of dollars and limiting access. The Stanford Accelerated Intelligent Neuromodulation Therapy, or SAINT, offers a solution. Using accelerated, high-dose, fMRI-guided data burst stimulation, Cole and colleagues reported remission in 90% of treatment-resistant depression patients within just 5 days. While these results are striking, larger sham-controlled trials are needed before widespread adoption. Wearable RTMS devices are another innovation. These lightweight, battery-powered stimulators reduce power use by 90% and can deliver treatment during everyday activities. If validated, they could shift TMS from clinics into homes, improving accessibility. But success will depend on rigorous testing and collaboration between clinicians, engineers, and regulators. In conclusion, depression is driven by disrupted brain circuits and neurotransmitter imbalances, which highlights the need for biologically informed treatments. TMS has shown clear clinical benefits helping to restore brain function by strengthening top-down regulation. Looking ahead, advances in protocols and technology will be key to improving accessibility and affordability.